17 on endometrial carcinoma. At the outset, I would like to thank NOGS and Department OBGY JNMC for giving me this opportunity. Without much delay, I request Dr. Sushma Deshmukh Ma'am, Honorable President NOGS, to give the welcome address.
A very good evening to all. Friends, this is a really very good season because we are all celebrating Christmas and we are all in the celebration mood. And recently we also completed this our wonderful conference as a Nagpur History Carnival with a good success. You all have witnessed it really it was very nice. And today it gives me celebration like feeling to welcome you all on this wonderful PG webinar, PG Star webinar with our Nagpur Vijaya Society in association with the Datta Meghe Institute of Medical Sciences. Friends, this is our series 17th and today we are going to discuss endometrial cancer. We know that it is really, cancer means really it is very dreadful things for the patients also and for we also while treating. And we need to know very important things while evaluating the patient. So that's why we can, in this end of this year, we can just have this in mind that we'll just learn so many things about the cancer so that we can be happier in the next year. And it will be a very happy year for all of us. So for this, Dr. Swati Dahife decided to venture to present this case of CA endometrium. And for this, we are having examiner as Dr. Virendra Kumar. We know from Bellary, he's a terrific academic person and we are listening him since many years. And really, sir, thank you very much. And Dr. Rajasri Sengupta, our own associate professor in Datta Meghe, and really both are very good academician and they will solve all the problems regarding this endometrium. Welcome to all. Then the second one is the Pulse of Wisdom and the topic is on update on endometrial cancer. So I welcome Dr. Nisha Singh, really amazing person and she will take you through the different aspects of and we need to know the update what is happening nowadays and it will be a very good academic feast for all of us. And the chairpersons are Dr. Chandan Kachru and Dr. Asha Jain. Welcome chairperson and Dr. Nisha Singh. And you know all the conveners, Dr. Anuja Bhalerao, Dr. Bhakti Guzar, Dr. Prachi Dixit, they are really the main support for conducting this PG Star CME. And you all the audience, PG every time, because last few days back I've been to Chandrapur, one young PG student, she came to me and she told me, ma'am, actually I wait for your PG Star series. So it's a very good gesture for me. So I think it is day by day is become popular because the faculties are very nice and my secretary, Dr. Pragati, is also there to deal all these things. Then MOC is Dr. Megha Karni, really. So all are doing, she decided to tie everyone in a one string. So again, I welcome you all and we'll start without delay. We'll start the series. Thank you very much.
So we begin with the first session of the evening, which is the case presentation on postmenopausal bleeding. We have with us today respected Dr. Virendra Kumar sir and Dr. Rajeshri Sengupta ma'am as the esteemed examiners. As we know, sir is the professor and unit head of Department OBGY WIMS, Ballari. Sir has been the president of Ballari Obstetrics Gynecology Society from 2019 to 21. Sir has 22 years of teaching experience. Sir has organized various live workshops and CMEs, and he has delivered the Professor P.K. Devi Audition at Nagpur and delivered a Dr. Vatve Audition in Sangvi. He has more than 100 presentations as a faculty and published numerous papers in various journals. He is the master trainer of HDP in Pregnancy Certificate course and contributed chapters in various textbooks. Our second examiner is Dr. Rajasri Sengupta ma'am. She is professor at DMMC and SMHRC, Vana Dongri, Nagpur. She has special awards and achievements and has been awarded the FICOG at AICOG Bangalore 2019. Yes, ma'am.
We can cut it short and go to the case right away.
Yes, ma'am. So with our experienced examiners, I hand over Dr. Swati Dahife, who is junior resident year 3, to present with her case. Swati, over to you.
Good evening, ma'am. It says host disabled participant screen sharing. I cannot share my screen.
Wait, ma'am. Just a minute. Ma'am, can you please recheck?
Yes, I can share my screen. Good evening, respected faculty. My name is Dr. Swati Daifare. I am third year postgraduate resident in Department of Obstetrics and Gynecology in Jawaharlal Nehru Medical College, Savangi. Today I am presenting a case of postmenopausal bleeding. My patient is a 55-year-old postmenopausal woman belonging to middle socioeconomic status. She is para 2, living 2 and tubectomized 32 years back. She came with a complaint of bleeding per vagina since 2 months. She was apparently asymptomatic 2 months back. Then she noticed bleeding through vagina, which was initially mild, with soakage of only half pad per day. Gradually, it increased over to 3 to 4 pads fully soaked per day with passage of clots. Bleeding was not associated with pain in abdomen. She's sexually not active since last 7 to 8 years. There's no history of similar complaints of bleeding per vagina in the past. There's no history of postcoital bleeding during sexually active years. There's no history of bleeding through any other orifices, bleeding per rectum, hematuria, or hematemesis. No history of any mass coming out of vagina or weight loss or loss of appetite. There's no history of trauma, fever, or pain. She has never received menopausal hormonal therapy, and she has not been screened for cancers like pap smear. She's married for 37 years.
Oh, wait,
she has
wait.
2 children.
Wait, Swati. So,
Yes.
when do you call as a case as a postmenopausal bleeding?
She
When
has
do you define? What is the definition of postmenopausal bleeding?
there are no menses for 12 months, and bleeding after that, it will be postmenopausal.
Okay.
bleeding.
So, whenever you are evaluating a case of postmenopausal bleeding, what is your concern? Why we have to take any postmenopausal bleeding as a serious issue?
So postmenopausal bleeding can be due to malignancy. So we
Yes.
have to evaluate. Yes, so we have to check whether
Suppose
it's
a patient,
malignancy or other.
suppose a patient comes to you and you'll say that you may have malignancy, and then is it like that?
No, so there are other causes also.
Okay. So what is the cause of, what is the percentage of having CA endometrium or genital tract malignancy in such patients?
So 10% can be due to CA endometrium. Other causes, most common cause is atrophic endometritis. But 5 to 10% can also be due to malignancy.
Yeah, it is not 5 to 10%. It is around 1 to 14%. It depends on which country you are evaluating. Suppose in India, it may be less. Suppose if you take in Western countries or in America, the incidence could be as high as 14%. Okay, the range is around 1 to 14%. So 1 to 14% of the postmenopausal bleeding woman can have CA endometrium. At the same time, the remaining 90% or 95% can have benign causes.
Benign causes.
As you told so many negative history, you probably ruled out so many other causes. Okay.
Yes, sir.
Right. Why do you think women will have postmenopausal bleeding? What is the cause? For example, you told atrophic endometrium, right?
Yes, sir.
One of the major cause of bleeding during postmenopausal period is atrophic endometrium. Why atrophic endometrium will have bleeding? Nothing is there, no?
Yes, sir.
Then why they should bleed? Right? Okay, I'll tell you the answer because we have very less time. Because atrophic endometrium as well as atrophic vagina, they are not static organs, they are all dynamic organs, and they are collapsed. Even endometrium is collapsed and vagina is collapsed. When collapsing occurs, there will be friction between the two surfaces, both anterior surface, posterior surface, as well as the vagina. So because of this, there will be micro abrasion occurs inside. Because they are not well supported by glandular support, they will have either endometritis, or they may have infection. This is the reason why they will have bleeding.
No.
Simply atrophic endometrium will not bleed because uterus is a dynamic organ. There will be constant small contractions will be happening, and there is friction between this endometrium. Okay. Otherwise, you will have doubt why endometrium should have atrophic endometrium should have bleeding. And similarly, senile vaginitis, because of the microvasculature, they can have bleeding. Okay.
Yes.
Continue.
Thank you, sir. Obstetric history, she's married for 37 years. She's para 2, living 2, both were full-term vaginal delivery, and she's tubectomized 32 years back. She attended her
What is the relation of parity and postmenopausal bleeding, or with related to your case?
Nulliparous women will tend to have more risk of CA endometrium than women with more parity due to estrogen.
Okay, nulliparous women are more likely to have. What is the percentage relative risk? What is the relative risk? Suppose you have para 2 living 2, and another woman is there, nulliparous. What is the chance of nulliparous woman chance of having a CA endometrium or genital tract malignancy? It is called as relative risk.
Relative.
What is the percentage? Because you asked so many negatives, no? That's why I'm asking.
Yes.
She did not use any hormonal therapy. She did not have. You have ruled out. Nice thing, you have ruled out. What is the relative risk?
Relative
For example,
risk, I don't know. Nulliparous will have higher risk, but I do not know, sir, relative.
It is around 2 to 2.5%. 2 to 2.5 factors. Okay. They are 2 to 2.5 times more than the parous woman. Okay.
Okay.
So this risk factor is
Swati?
very important. Yes, ma'am.
Yes, ma'am.
You told about nulliparity relationship with CA endometrium.
Yes, ma'am.
But do you want to comment about CA cervix? Can that be one of your causes of postmenopausal bleeding?
Yes, ma'am.
Is
CA
nulliparity also a risk factor for CA cervix?
Or multiparity. Here
What
we
is
are
the
not
risk factor
discussing
in
only.
cervical cancer?
See the ulta of CA endometrium, multiparity. More parous women are more likely to have CA cervix, right?
more sexual.
Early onset of sexual activity.
Sexual
early
activity.
menarche.
Multiple partners.
That can be one of the causes of postmenopausal bleeding. So you have to keep it in mind when you take your history.
Yes, ma'am.
Yeah,
See
please
here,
continue.
you know that it is a case of CA endometrium, but in examination you cannot tell like that. You have to know all aspects of genital tract malignancy.
Yes.
Okay.
My patient attained menarche at the age of 13 years. During her menstrual reproductive year, she had regular cycles of 28 to 30 days with bleeding for 4 days, with soakage of 2 to 3 pads, half soak per day, with no history of passage of clots or dysmenorrhea. She attained her menarche at the age of 50 years, that is 5 years back.
Is it normal? Is it normal attaining menopause at the age of 50 years?
Yes, sir. Up to 50 years is normal, sir.
No, what is average age in Indian women versus in Caucasian women? You have to know the average age of menopause in Indian ladies.
45 to 50 years for Indian women.
No. Please tell me
45.
the specific answer. Is it the same for Western women and
No,
Indian
ma'am.
women? So in whom it will be later?
Any guesswork? We told no in the
Indian-
beginning. The Western
Indian
women are
women-
more likely to have endometrial carcinoma, means they are more likely to have later menopause compared to Indian women. Right?
Okay.
So
Yes,
it is 51 years in Caucasians and 47.5 in Indian women. Okay?
Exactly.
Remember. Yeah, please.
What is the relation of menopause and CA endometrium?
if she achieved menopause earlier, that means less exposure of estrogen, there will be lesser risk of CA endometrium. If menopause is attained later, there will be
Late
more
menopause. You
deviation.
can give a specific answer instead of telling like this. Late menopause and early menarche are more associated with chance of
more
like that. You should tell. Okay.
malignancy. Okay.
Continue.
Past history, there is no history of diabetes, hypertension, thyroid disorders, asthma. There is no history of blood transfusion in the past. She had only undergone tubal
Wait. You are asking no history of diabetes, hypertension. Is it like routinely asking, or is there any specific reason?
Hypertension, thyroid disorder, these are associated with CA endometrium also, and this should be screened in every patient.
Okay, what about PCOS?
PCOS is also high risk for CA endometrium as it more unopposed estrogen. So it
Okay.
will also increase the risk of CA endometrium.
How
What
much?
is corpus cancer syndrome? What is the triad of
One
corpus
triad of
cancer?
hypertension, obesity, and diabetes.
Right.
Okay.
And how
Suppose
is
if it is
PCOS a risk factor?
Ma'am, PCOS, there will be more unovulatory cycles, so that is more unopposed estrogen, which will increase risk of CA endometrium.
Correct.
Any relation between
family-
obesity? Because most of the time we see.
Yes, obesity, there will be more fat, so more conversion of androgens to estrogen due to aromatization of fat, which will also increase
What is the relative
estrogen.
risk? What is the relative risk? For example, a woman who is just overweight, who is morbidly obese, whether they carry the same risk?
So morbidly obese will carry more risk than overweight.
No, you should know specific answer. Anybody can guess, but what is the risk factor? For example, our BMI is more than 35. It is morbidly obesity, right?
Yeah.
How
Yes.
much? It is 10 times more than the woman who has got normal weight. Okay, you must know all these things because CA endometrium, anybody can tell what is the staging and all. But as a postgraduate, as a clinician, you must know all these things. Okay?
Yes.
Right. So morbidly obese woman, relative risk factor is 10 times. 10. Okay.
Family history, there is no history of ovarian, breast, or
No, you asked
endometrial.
no history of blood transfusion in the past. What does it mean? Why you
So
asked
she,
that?
she
Any
came
relation
with
between CA endometrium and blood transfusion? Or
no,
any?
sir, she came with complaint of bleeding through vaginum. So if she has shown outside or transfused with blood, so I wanted to know that history.
No, that is not a past history. That will be a present history. It is a continuation of her symptoms. It cannot come in past. Okay.
There is no history of ovarian, breast, endometrial cancer or any malignancy in the family. Personal history.
Why
she
you are
consumes
asking
mixed.
this? Why you are asking this?
So CA endometrium has a genetic link as well. There's mutation of gene that can be passed down in generation. So I wanted to know if
What is that
her
syndrome
mother
known
or
as?
sister. What's that?
What is that syndrome? Suppose you ask no genetic predisposition baby there in certain families.
Lynch 2 syndrome, sir. Hereditary non-polyposis colorectal cancer.
Okay. So that is the one which has got
genetic link.
maximum relative risk of developing. It is almost 20 times more than in normal population.
Normal.
Okay. Right.
Yeah.
At what age you should do the testing for oncogenes?
When do you perform testing?
What is the optimum age? And if it turns positive, then what is your plan of management?
Suppose the oncogene comes positive, and patient is already
high risk of colon cancer and endometrial malignancy.
So then what do you do? At what age you would want to test this patient?
Okay, read.
Sorry, ma'am, I do not know that.
Okay.
She has normal sleep pattern. Her bowel and bladder habits are regular. There is no history of smoking, tobacco, alcohol consumption, or any addictions. Examination. On examination, patient is conscious, oriented to time, place, and person. Her weight is 54 kilogram, height is 150 centimeter, and BMI is 24 kilogram per meter square. Pallor is present. There is no edema, cyanosis, clubbing, icterus, or lymphadenopathy. Her pulse is 90 per minute, regular. Blood pressure is normal.
You can go to directly genital tract examination.
On per abdominal examination. On
That's
inspection,
okay, because we don't discuss all those things. Right.
Local examination, external genitalia is normal. There's sparse pubic hair seen. Labia majora, minora normal. There's no growth or lesion seen over perineum or labia. External urethral meatus normal, and no hemorrhoids or skin tags seen on local
You
examination.
should not write normal. You should write appropriate for the age. Okay. You cannot write normal. Appropriate for the age. Better. That is the better terminology. Right.
Okay. First speculum examination was done, which showed cervix, vagina healthy. There was no growth or polyp seen on cervix, no growth seen in vagina. Blood was altered, dark color blood was seen trickling out of cervical os on first speculum examination. Bimanual examination was done where cervix firm in consistency. Its surface was regular, directed downwards and backwards. Uterus was 12 week size, anteverted and mobile. Bilateral furnaces are free. There is no nodularity felt in pouch of Douglas, and there was no cervical motion tenderness. Per rectal examination was done. Tone of external anus sphincter good. No growth felt in rectum. Rectal mucosa free. No mass felt through the anterectal wall. And bilateral parametrium free. There is no nodularity felt in pouch of Douglas. And on per rectal examination, no blood was stained on gloved finger.
What is the purpose of doing per rectal examination?
So when she complains of bleeding per vaginum, sometimes it can also be bleeding through rectum, which she might get confused when she sees blood on
That is one.
sanitary
Okay.
napkin. So it can also
Any
be
other thing?
hemorrhoids or associated malignancy in colon. So we should rule out that.
No. We have to tell in the perspective of genital tract malignancy.
Yes.
What is the relation of doing PR in the case of you are suspecting genital tract malignancy?
Yes, sir. Spread to sir bowel mucosa.
Yes.
Then-
Why is it important? Why do you want to
if-
know that?
If mass is felt through per rectal examination, that means the genital malignancy has spread to bowel mucosa and it is a higher stage of cancer.
Okay.
Right.
How many times would have seen? We are yet to see even grade 4 C endometrium. More common answer is because in India, which is a common cancer in India? Which cancer among women, gynecological
cervix.
cancer is the CS cervix. Okay.
CS
So
cervix.
sometimes we may having endocervical growth or adenocarcinoma. Okay. External cervix may be normal. So we want to see how is the parametrium, how is there anything. So instead of telling all these hemorrhoids or colon cancer, we should concentrate on our field. Okay.
Yes.
That also again CS cervix more important for us than C endometrium.
Yes.
The endometrium is important, but more important is CS
CS
cervix.
cervix is more common.
Yeah. So basically to look for parametrium, to look for any suspected ovarian malignancy, all this nodularity you told. No? So don't tell the answer of colon cancer or hemorrhoids or CA rectum. You talk about genital tract malignancy. Okay.
Yes.
But in your findings here in per rectal examination, you have not actually commented in the cervical area, which you should as a gynecologist doing a PR. You should
No
comment
mass
on the
felt to anterectal.
in where, but in the region of cervix. That's what you should say.
Okay, ma'am. Thank you. Summary: my patient is 55-year-old postmenopausal female, para to living to
So what
tubectomy.
next? What will you do for her now?
So I have done investigation, sir. Hemoglobin is 8.3 gram%. WBC count is 8,600 per cubic millimeter. Platelets 2.2 lakhs per cubic millimeter. Peripheral blood show normocytic normochromic RBCs. Hemoglobin electrophoresis showed a pattern of hemoglobin. Her bleeding time, clotting time, coagulation profile was within normal.
Okay.
As her hemoglobin was 8.3 gram%, we transfused her to packed rates PRC. USG was done, which showed uterus measures 91 millimeter by 73 millimeter by 54 millimeter, shows coarse myometrium. The endometrial cavity reveals hypoechoic heterogeneous contents with minimal vascularity. Endometrial thickness is 22 millimeter. There was no focal lesion seen, no adnexal mass noted, no free fluid in cul-de-sac, and liver and spleen were normal.
Okay, we'll go to that later. What is the role of pap smear in such cases? What is the role of pap smear in postmenopausal bleeding? Whether you would like to get pap smear in this patient?
Yes, sir. So we did pap smear also, which was negative for malignant cells. Right.
No. What is
cervical cancer is more.
What is the typical report of pap smear? How do you describe a typical normal pap smear report? What do you mean by NILM? Suppose if you what system you are following?
Yes, sir.
What system you are following for pap smear reporting?
Bethesda system.
Bethesda.
Bethesda.
Okay, there in the footnote they would have written NILM. Means what? NILM. It is negative for intraepithelial lesion or malignancy. You should not sell only malignancy. It is always NILM. Is there any role of pap smear?
Yes, sir. As cervical cancer is most common cause, we should rule out CS cervix also.
Can we rule out endometrial malignancy by pap smear? Pap smear is not only for CS cervix, no?
Yes, sir.
It is exfoliative site. Whatever cells are shed into the vagina, you are collecting it. Okay.
Yes.
Sometimes you may get
Yes.
even the suspicious cells on
Endocervical
pap
and
smear.
endometrial.
Okay. So
Yes.
any pap smear suspicious cells, if you get on pap smear, it is you are bound duty to rule out both CS cervix as well as C endometrium. I am not talking about this patient in general. If you have any suspicious, okay. So what are the
Yes.
suspicious cells you are likely to have? You will have ascus or agas. You know what is ascus? ASCUS.
Yes, sir.
Okay. Sometimes C endometrium can also shed abnormal cells into the endocervical canal or into the vagina. So you may pick up endometrial cancer, but it is not recommended to screen C endometrium through pap smear. That you should understand. Okay.
Yes.
Right.
Okay.
So what is the best training modality for C endometrium then?
C endometrium surgery is the best modality.
No, screening. I'm asking screening. Like pap smear sir just now said that it is better for cervical malignancy.
Yes, ma'am.
So
Ma'am,
then what is the
biopsy of endometrium. Biopsy of endometrium.
biopsy would be a screening method? Do you think you can say it is a screening method?
No, diagnostic.
So you should say that as far as C endometrium concerned, there is no reliable specific screening test available. That should be your answer, right?
Okay.
But still we can do some screening. How do you do that? At least in high risk patients. You have written some endometrial thickness 22 mm.
Yes, sir.
Can we use ultrasonogram as a screening modality at least to some extent, even though it doesn't qualify?
Yes, sir. Thickened endometrium will show.
What thickened in a postmenopausal woman? When do you call it a thickened endometrium?
If it's endometrial thickness is more than 15 millimeter, it's significant
50.
and should.
No.
Come again.
What is the cutoff? What is the cutoff of endometrial thickness on a TVS in a postmenopausal woman to raise a high index of suspicion of malignancy?
5 millimeter.
5 millimeter. Okay, I say 4 mm.
4 millimeters.
Suppose somebody will say 3 mm. What is the correct answer? Suppose if you take 5 mm, how many malignancies C endometrium you will miss? Suppose if you take 5 mm, how many malignancy will miss? So that's why we want to have really most of the people will go 99%. So 99% negative predictive value is there for 4 mm cutoff.
4 mm.
Okay. Suppose 5 mm is not 99%.
Okay.
So even if you take 4 mm, still you can miss some malignancy. Suppose if the thickness is 3 mm, 99% unlikely that she has C endometrium. That is the meaning of that. Okay. So 4 mm, suppose how many cases you will miss?
For 4 mm, so 99% chance it's not a malignancy. 1% it can.
No, actually, according to the study, they have conducted study. 1 in 3, 39 cases may be missed if you take 4 mm. Okay, if you take 5 mm, 1 in 250 cases may be missed. Whereas if you take 3 mm, 1 in 380 may be missed. So because the difference between 380 and 340 is very less, the research have set the cutoff at 4 mm.
Oh,
Got it? This is not 5 mm. Nowadays
Yeah,
we
4 mm.
consider 4 mm because negative predictive value is 99%.
So
Okay.
Swati, your
Thank-
patient's endometrial thickness is how much?
22 millimeter, ma'am.
So is it normal?
No, ma'am.
But can you have some other diagnosis rather than malignancy with this type of?
Yes, ma'am. Endometrial hyperplasia can also have endometrial high endometrial.
Okay.
What would you more want to rule out?
And I want to
Because-
rule out malignancy.
No.
I'm
That is
asking
all
your
right. That is the
differential
first.
diagnosis.
Any
At
other case?
22 mm, other than malignancy, is there anything else on your mind which you want to rule out?
And
Before
that too, she's
getting
bleeding
panicky
heavily.
that it is a malignancy, it can be anything else.
Yes, ma'am. Benign lesion like endometrial hyperplasia, endometrial polyps.
Polyp, yeah.
Polyp
Madam
is
wants
more
to know.
the answer. Okay.
Yes.
Hyperplasia, your echo texture will be able to tell you. And a hyperplasia of 22, very less likely. Anything around 2 centimeters, first thing you should rule out is a polyp. If this is not a postmenopausal, if she is a premenopausal woman, a younger girl with 22 mm ET, a good technique to do imaging of a polyp is,
What
Ma'am,
will you do?
MRI.
huh?
No.
Why? Why do you want to burn a hole in her pocket, dear?
Your college is rich for everybody will do MRI. Huh? What is the simplest test, Amma, to rule out polyp? Have you heard of sonosalpingogram, sonohistogram?
What is SIS?
Yes. Yes.
What is SIS?
Saline infusion
Infusion.
sonogram.
Sonogram.
Okay. It is also called as sonohistogram or SIS, saline infusion sonogram. That is the
Then
cheapest.
sonogram.
It can be done on outpatient basis. MRI is reserved for
And
other cases. Okay. See, what is the how do you should estimate endometrial thickness? Suppose you are doing TVS, how do you estimate endometrial thickness? In what axis? Is it transverse axis or longitudinal axis? Suppose the endometrium should be seen from fundus to the cervix up to cervical canal. And where do you take the thickness? Suppose at fundus it may be more, at some level it may be less. Which one you will take?
so I do not know, sir, as ultrasonography.
Yeah, ultrasound. Gynecologist should be the ultrasonologist. You cannot depend on radiologist. Every
Yes.
gynecologist should learn ultrasound. At least our own organ, we should know how to do scanning. You should not depend on others. Okay?
Yeah.
It is
Yes.
anteroposterior. The measurement is taken in the longitudinal axis of the uterus. The maximum endometrial echo is taken. Suppose in 1 year it may be 3 mm and another year it may be 6 mm. You are going to take the maximum thickness rather than the lower thickness. Okay?
No. Yes.
Right.
So hysteroscopy was done,
One
which showed.
minute. Moderators, please stop us if we are shooting out of time. Okay?
Yes, sir.
Okay. Next slide.
Hysteroscopy was done, which showed endometrium thick and fluffy. Necrotic lesion was seen near left ostium over anterior uterine wall. Bilateral ostia could not be visualized due to thickened endometrium. Biopsy was taken from abnormal lesions, followed by curettage of uterine cavity, and those samples were sent for histopathology examination. The histopathology report came back positive for endometrial carcinoma, endometrial type 1 endometrial carcinoma. We have called patient for follow-up for further evaluation, sir.
Okay. So before this, we'll go to management of carcinoma later. What are the, suppose hysteroscopy may not be available everywhere. What is the simplest procedure you can do?
So
How
we
to
can
take,
do endometrial
you have
biopsy.
taken a hysteroscopy guided biopsy, all right.
Yes.
Okay, but why did you curate that uterine cavity? Not necessary. When you have taken directed biopsy,
Yes.
The curating of the uterine cavity was not necessary. That we will come to little later. But for a general gynecologist who does not know about ABCD of hysteroscopy, or sometimes hysteroscopy may not be available, then how do you take endometrial biopsy? How do you take? And this hysteroscopy is all right. So endometrial biopsy, sometimes it is done even before the ultrasound examination. Sometimes you are in the OPD, you are seeing, immediately you take and then send her for, okay. Whether you do after ultrasound or before, that is not a question here. How do you take endometrial biopsy? With what you will take? Whether you will do DNC, like that I am asking. Answer, Dr. Swati.
Yes, a biopsy.
How you take biopsy? With
Do you
whether you
do
will
it
do
EB in your OPD? Do you
Yes,
do?
ma'am.
How do you do it?
Ma'am, we give mesoprostol to dilate cervix, and with the help of the endometrium biopsy forceps, we take endometrial biopsy, ma'am, and send for histopathology.
Do you need to give meso?
If os is closed to.
os will be always closed. When it will be open? External os may appear
Then
open.
what
Internal
is
os is
the
always closed.
principle of taking an EB on OPD basis? You can actually give her a meso and do a hysteroscopy or a DNC under anesthesia. What is the difference? Sir wants to know the technique, the instrument.
Is for the
and what is
benefit
the
of the
advantage?
people who are already.
I'm sorry, sir.
I think he logged off. Yeah, with what is the instrument equipment? What is it called? With which you take
Endometrial
a-
curate.
Have you heard of a pipelle?
Yes, ma'am.
What is it?
Instrument take biopsy. Sorry, ma'am.
What is the advantage of having a pipelle versus a regular DNC and diagnostic hysteroscopy? What is the use? How it is? Have you seen a pipelle? Have you seen an EB curate? Okay. You read about it, okay? It is
Yes,
an
ma'am.
important endometrial sampling technique.
Yes,
Now,
ma'am.
coming to the next question, suppose your sampling technique is not giving you adequate amount of tissue. Then how do you go about diagnosing? EB तो आप ले लेते हो ओपीडी में, फिर भेज दिया, उसके बाद
Yes.
क्या करवाते हो? फिर पेशेंट को कहाँ भेजते हो? उसके बाद सोनोग्राफी करवाते हो?
Yes, ma'am.
Then when will you get the report of EB?
Ma'am, we send it for histopathology examination, and after a few days we get histopathology report, ma'am.
So my question is, rather than doing an invasive procedure like a pipelle or an EB or a DNC or a hysteroscopy, can you use TVS screening as a screening method for diagnosing malignancy?
Yes, ma'am. On
Yes,
transference.
you can. And in fact, it is one of the most widely used techniques nowadays. Okay, for
Yes.
cervical cancers, we have pap smears, we have liquid-based cytologies, and for endometrial cancers, a good TVS with a good resolution machine can almost detect malignant-looking endometrium, bad-looking endometrium. Cutoff for a postmenopausal is 4 millimeters. Anything more than that, you have to have high index of suspicion of C endometrium and accordingly investigate.
Okay.
Now you tell me, when this patient, where is sir? Did he log out?
Hello?
In this patient, sir, yeah, welcome
Yeah,
back.
I lost the
Yeah.
signal.
Oh, we figured that out.
Yeah.
So
Can we have sampling failure? Sometimes you take a
yes,
biopsy
that's what I
and
asked
you
her,
don't
sir.
have. You don't have. Did you discuss this, madam, during this?
Yes, sir. Yes, sir.
Okay.
We did.
What is the percentage?
The percentage, I do not know, sir.
Yeah.
Sorry.
Because examiners are fond of percentage because they want to know what is the risk or what is the percentage. See, up to 40 to 50% of the times you can have failure. Hello? Can you hear me? Hello?
Yes,
Madam,
sir, we can
unmute.
hear.
Yeah,
Sir, we can hear you.
Okay, fine. Continue. See, nowadays you should remember that you should not tell the answer D and C. Is always you should tell either PPLA or the smallest possible cannula should be used. Okay?
Yes, sir.
Okay. So no answer. DNC is considered as barbaric for our women. You should use either the PPLA or we have Endomed. Nowadays, so many companies have come with a very small cannula of the diameter of maybe 3 or 4 mm. You can use such things and take a sampling. It is as good as DNC.
Also,
Never
in
ever
cases
tell
where
the
you
DNC
have an
answer.
access, you should always couple your DNC with a diagnostic hysteroscopy. You should not do a blind DNC if you have access to a hysteroscopy. Okay?
Yes. Okay.
Yeah. In your exam, you should specify this point. But in areas where you're not working, where like peripheral areas where you may not have access to a hysteroscopy, then as sir is suggesting, an EB or any type of endometrial sampling is good. Don't leave the patient without doing a sampling.
See, another point, because so many pages may be on live stream, can we do hysteroscopy in a already established case of C endometrium? You are doing hysteroscopy, you are pushing a lot of fluid, and you are saying that she is not sterilized. So the malignant cells may enter the peritoneal cavity.
Peritoneal spread.
Is
She's
it
not
true
even-
or is it only hypothetical?
Or if at all you are
Swati?
doing, what should be the pressure settings?
Pressure should be low to prevent spread through vascular channels. Huh?
Yes. It is said that it is only hypothetical. If at all you are already strong suspicion and you are doing hysteroscopy, you must keep the distension pressure maybe less than
As
80
low as-
millimeter of mercury. If you keep it more than 100, 140, then the risk is more. Okay?
Yes.
Right.
So what is your plan of management now for this patient?
Ma'am, we have called the patient for evaluation and management, ma'am. We'll do MRI for to see for spread to other organs, and we'll do staging laparotomy, ma'am.
Is it what kind of staging is CA endometrium? For example, CA
surgical
clinic.
staging?
Yeah, surgical.
Yeah,
It is
always.
nowadays it is a comprehensive surgical staging. That is the terminology used now. It is no longer just surgical, comprehensive surgical staging. Okay, before we go for endometrial carcinoma, every gynecologist should know about endometrial hyperplasia. Okay, what is the risk of endometrial hyperplasia and CA endometrium? Because the moment you say that endometrial, you should know the percentage. Based on that, you can offer the patient treatment. Why these figures are important? For example, you get what are the kind of histopathological report you will have with endometrial hyperplasia? What are the 4 types you will have endometrial hyperplasia reporting?
Simple or complex
Yes.
with ATP or without ATP.
Yes,
Right.
correct.
Okay, you got it. So suppose you have complex hyperplasia without ATP. What is the chance of malignancy? You may get the report. Then you, as a gynecologist, you should know to counsel the patient to regarding hysterectomy or medical non-surgical treatment. You should know.
Okay.
Okay. So all these days, even today, the famous study by Kumaran, 1985, that again the study is not repeated. If you have simple hyperplasia, chance of malignancy is only 1%. If you have complex hyperplasia, the chance is only 3%. If you have simple with ATP, it is 8%. If you have complex with ATP, it is 27%. So the reporting of simple hyperplasia with or without, you will know whether to counsel the patient regarding further management. Okay. Sometimes endometrial hyperplasia may have occult malignancy. The report may come as hyperplasia, endometrial hyperplasia. Still, they can have well-differentiated endometrial carcinoma. What is the percentage? Again, up to 25% of the women with endometrial hyperplasia, especially in postmenopausal status, are likely to have occult malignancy. You may have missed it. Okay. So that's why all these figures help us in counseling the patient. Just because it is a simple hyperplasia, you may not neglect the patient. And complex hyperplasia with ATP, you should never take it lightly. Right? So this
Yes.
factor about endometrial hyperplasia, especially in postmenopausal women, you should know. And if it happens in premenopausal women, then you have the chance of giving them progestin therapy. So this differentiation should be well known to you. Okay, madam, please continue.
Yeah, so what is the plan of management? You said a surgical staging laparotomy.
Yes.
What are the care you are going to take? How are you going to proceed? Can you just enumerate the steps?
Madam, before you complete, is the histopathology report complete?
No, that's why I am asking.
Yeah. What do you mean by type 1, type 2? Suppose
Sir,
sometimes you get type 2. What do you mean by type 2?
so type 2 endometrial carcinoma, it's a more aggressive type of carcinoma. It's a clear cell carcinoma. And type 1 is a less aggressive endometrioid
No,
type of
not
carcinoma.
about the aggressive or this thing. Type 1 is basically happens
Estrogen
in women. Estrogen dependent, and type 2 is non-estrogen dependent.
non-estrogen.
Type 2 happens more often in old ladies. Type 1 mostly perimenopausal.
Relatively young.
See, grade is not mentioned here. Okay. The grade of the cancer is not mentioned. That is all very important to, as madam asked, what steps you will take, whether it's grade 1, grade 2, grade 3. Madam, please.
Yeah. Can you enumerate, Swati, how you will go about with your surgery? Just tell me the steps one by one.
I will do hysterectomy with the bilateral salpingo-oophorectomy.
Do you want to do laparoscopy, or you want to do an open abdominal one, or you want to go ahead for a NDVH? What is your preferred route?
No, what you do in your college, you can answer.
If it is associated with prolapse, we'll go for vaginal route. If it's
No,
not
no, no.
associated,
In your
a
case, where is
malignancy?
the prolapse?
In this
there
case,
is no prolapse.
please
So,
tell me about this particular case.
ma'am,
What is your plan
abdominal
of management? Yeah, bolo.
Ma'am, abdominal hysterectomy with bilateral salpingo-oophorectomy will send the specimen for frozen section. If it
Okay, just tell me the steps. What are the care you will take when you are doing an abdominal hysterectomy for a known case of endometrial malignancy? Is it going to be routine like you do for a fibroid? Or are there going to be some changes?
sorry, ma'am.
Okay, you have to read about it.
Yes, ma'am.
So whether is there any peritoneal cytology is required during comprehensive
Yes, peritoneal
surgery?
cytology is sent along
What
with
is the role of pelvic lymph node dissection, para-aortic lymph node dissection? Should we do it or not? All these things, who will tell? See, it is there. It is not just TH, BSO. You have to do TAH plus BSO plus peritoneal cytology and pelvic node lymph node dissection.
lymph node dissection.
What
You
about
have to read
para-aortic
about
lymph node
types
dissection?
of hysterectomy.
Okay, yes, ma'am.
Yeah, sorry.
What is
sir.
the role of para-aortic lymph node dissection? When do you do para-aortic lymph node dissection? For routinely, we don't do it. In whom you do?
So in frozen section, if the myometrial involvement is more than 50%, then we go for lymph node dissection.
Okay. Sometimes, if you don't have frozen section, depending on the prior histopathology report available, suppose if grade 3 or more, or if it is serous or the clear cell carcinoma, then you will do otherwise, at least you should do pelvic lymph node dissection. Why we should do pelvic lymph node dissection? Suppose if it comes as positive, whether they require any treatment extra. See, the survival, progression-free survival, it is called as PFS. Okay. Ultimately, the aim of surgery is, as far as possible, you must clear the cancer burden in the patient. Okay. So that they will have progression-free, in the cancer progression-free survival. One of the principle of oncology is this. So we have to remove as many nodes as possible. Ultimately, they may turn out to be positive. If you remove maximum nodes which are positive, they are more likely to survive than a patient who has not undergone pelvic lymph node dissection.
Lymph node dissection.
Okay, that is the principle. You may not be able to do all the surgeries, but at least you should know the principle.
Yes, sir.
Ma'am.
Yeah, no, I think we're good. Is there any role of neoadjuvant chemotherapy for CA endometrium? Are they
Dr. Swati.
amenable to chemoradiation? Would
And
you
we can
want
go
to
for
give radiation
radiotherapy
and
to prevent
chemo
we can give radiotherapy to prevent recurrence after surgery, ma'am.
of to all cases?
No, those who have a high risk of recurrence, like aggressive tumors, or
No.
in which
What
lymph
is the
node was
decision for radiation and chemo post-operatively depending on? Is it related to some factors or all malignancies you will give chemoradiation?
not all malignancy.
What are the factors what are the risk factors? What are the surgical findings? What are your reports?
Ma'am,
You
if it's
do what
aggressive,
sir just now asked you.
if lymph
See,
nodes are
yeah, continue.
Yeah,
if
if
lymph nodes
node-
are positive, then
Then?
radiotherapy should be
Why?
given, ma'am,
Why?
to prevent spread
Yes.
to distance metastasis.
Why it will spread? You have removed it, no, already? Then
Yes,
why
ma'am.
it will spread? Give a proper answer. Please read
See,
about gynae-oncology. It's a very
Yes.
important topic for your exams.
Yes,
you
ma'am.
you would have
We just
removed
have
the
2 or
nodes.
3 main cancers and you should know everything about all ovary, cervix and
And
endometrium.
See, there is something called as micrometastasis.
Hmm.
Okay,
Yeah.
that
Yeah.
should be the answer, because you would have physically removed the macro disease, but micrometastasis will always be there, right? That is
Yes.
one. And every time you are telling that clear cell carcinoma aggressive, what is the percentage? If you take, suppose 100 cases of endometrial carcinoma, how many will be endometrioid, how many will be clear cell, how many will be this?
Up to 90% will be, most common is endometrioid.
Yeah.
Up to 90 cases are endometrioid.
Yeah, that's why you must know only
region.
about endometrioid. See, never tell that only 10% of the patient who rarely we see. So depends
Yes,
on the myometrial invasion, depends on the grade, depends on the associated risk factors. We decide adjuvant chemotherapy. Is there any role of neoadjuvant chemotherapy in such patients? What do you mean by neoadjuvant? What do you mean by
Neoadjuvant is given before surgery, and
Okay.
adjuvant is given after surgery.
anything in between? One is after surgery, one is before surgery. Anything in between is there? It is called concomitant chemotherapy. Where do you give concomitant chemotherapy? In which malignancy will give? Concomitant chemoradiation is the order of the treatment for CA cervix. Understood? So most often neoadjuvant chemotherapy is given for CA ovary. Adjuvant chemotherapy is given for either CA cervix or CA endometrium. Concomitant chemoradiation is the treatment of choice according to ICMR for CA cervix.
Yes.
So all these terms are concomitant, adjuvant, all this you must know. Suppose this patient requires adjuvant chemotherapy, what drugs you will give?
Sorry.
You don't know. You must have read and come. Paclitaxel and carboplatin. Okay, that is the combination which is given.
Yes.
Okay. And brachytherapy is given, or external beam radiation. Is there any role for vaginal brachytherapy? So you must know all these things, right? Since you are presenting a case of C endometrium, it is your duty to read everything about C endometrium. Okay?
Yes, sir.
Okay. Anything else, ma'am?
No, I think we're good. I think we have overshot the time also.
Yes. Okay. So I think we have covered most of the basic factors. No, we are not overshot. I think time allotted was 1 hour.
But it was wonderful discussion.
Yes.
Very
Thank
nice.
you.
We also enjoyed a lot.
Thank you.
Can we just, we'll have one group photograph before
Yes.
leaving. So
Yes.
all faculties are here. Ma'am, please. Corona people, please.
Yes,
I
ma'am.
think Ruchir is there, na?
Ma'am, this is Piyush.
Piyush, please have a photograph.
Just give me 1 minute, ma'am. Done.
Done?
Thank you.
Thank you.
Thank you.
Okay, thank you.
Thank you.
Thank you,
Thank you, Sushma
examiners.
ma'am and Pragati ma'am. Thank you, Bhakti.
Thank you, Sen Gupta ma'am. It
Thank
was
you,
a
sir.
nice-
It was really
It was
wonderful
a-
discussion. Yeah.
Thank you.
Thank you, sir and ma'am, for shedding light on the various aspects of postmenopausal bleeding and guiding the PG students on what they should keep in mind while presenting such cases. Thank you, sir. Thank you, ma'am, for this wonderful discussion that we had regarding the case, sir.
Really, I should. It was such a in-depth discussion and it was such an interesting discussion. So much to learn, so much new things we learned from this discussion today. Really, thank you, Dr. Virendra Kumar. Thank you, Dr. Rajan Gupta. And
Thank
thank
you.
you, Swati Daifare. It was very nice presentation. Very good discussion has evolved. So, really,
Thank you.
lot of learning from this discussion.
We shall now proceed with the second session. It is the session on Pearls of Wisdom, an update on endometrial cancer by esteemed speaker, respected Dr. Nisha Singh, ma'am. This session shall be chaired by our respected chairpersons, Dr. Chandan Kachru, ma'am, and Dr. Asha Jain, ma'am. Dr. Chandan Kachru, ma'am, is a senior consultant and obstetrician and adolescent medicine consultant at Cloud9 Hospital, Sector 47 in Gurgaon.
I will request Dr. Asha and Dr. Chandan to open their videos. Dr. Asha, Dr. Chandan. Yes. Dr. Chandan has joined. Just give a call to her. Okay, I'll just give a call. Hi, Dr. Nisha Singh.
Hi, good evening. So,
So I'll just give a call to Dr. Chandan. Was she seen?
should I introduce Dr. Nisha and start the program meanwhile?
Yes, definitely.
Good evening, ma'am.
So, welcome, dear Dr. Nisha. So, she is Unit Head and in charge, Genital Cancer Control Unit, KGMC Lucknow. She's the Vice President, Association of Gynec Oncologists of India, Vice President, Lucknow Obstetric Gynec Society, VP UP State Chapter of AGAI, Joint Secretary, AOGEN India, member Foxy HIV/AIDS Committee, and has started Hereditary Gynec Cancer Clinic at KGMU. She has a lot of experience. She's had gynecology, oncology trainings from Stanford, Barts, RUH Canada, and TMH Mumbai. She's had her endoscopy training from AIMS, New Delhi. She has 24 projects, more than 100 publications, more than 15 chapters. And she's the editor, Gynec Onco Module for UP Government 2023, Nodal Officer for Trainings and CME in Gynec Onco for UP Government, guest speaker, more than 250, paper presentations, more than 25, journal reviewer, more than 40. She's helped organize AOGEN India 2017, AGAICON 22, UPSC AGAI 23, more than 80 CMEs, and is a master's trainer in more than 17 trainings. She has very many awards. UP State Chapter Award AGAI 2022, Asia Pacific Medical Excellence Award Appreciation Certificate, NHM UP and MP, Asia Top 50 Academician Award, Best Paper Oncology Foxy 2010 and 22, Best Paper AOGEN India 2015 and 19, Best Faculty Award, 6th ABA Bharat Jyoti Award. Welcome, Dr. Nisha. It's been great actually reading your CV, because We know you so well that we've really not been through the CV. So with such an illustrious CV, I am anxious, and eager to listen to your talk on endometrial cancer after that scintillating case presentation and the examination of the student. Welcome.
Thank you so much, Dr. Asha. And thank you, Dr. Sushma and Dr. Pragati, for inviting me here. And I hope I do justice to the topic given to me. And I think this slideshow has to be, unshared so that I can share my screen. So though I felt that 30 minutes will be less for endometrial cancer, I've tried to make it for the PG level. And so some slides, maybe I will just, can you see my slides?
Yes,
Yeah,
we can see your slides.
Yeah.
Yeah, now it's full screen.
Yeah, and I will also like to just a second, make this. All right. So starting with endometrial cancer, as we have heard through the case discussion also, among the developed countries, it is one of the most common gynae cancers. But in Indian women, it is the third most common. The median age at diagnosis is 63. That's why postmenopausal women. But over the last decade, we have seen an increase in the incidence in younger women. 80% are diagnosed in early stage, but still there are cases that are coming to us in advanced stage. 5-year survival rates are good for the localized disease, reaching 96%, but for regional and metastatic disease, the survival rates drop down. These are some of the pictures of various cases that we have had. Now, risk factors were discussed somewhat in the case presentation also, just to add to the list. Obesity, hypertension, diabetes was discussed, but chronic anovulation, tamoxifen therapy, presence of any estrogen secreting tumor, endometrial hyperplasia was discussed as a precursor. Family history is important, and history suggestive of Lynch syndrome, that is presence of any other cancer which is part of the Lynch syndrome in the same woman exposes her to the risk of a CA endo also. There was some discussion on the role of screening. I think just see the nose. Asymptomatic women without risk factors, there is no screening recommended. Asymptomatic tamoxifen users also no screening recommended. Women who have a granulosa cell tumor, if hysterectomy is not being done, then an endometrial aspiration is recommended. But if it is negative, no further screening. So where do we need the screening? So in general population, there is no role of screening. But if there is a woman who has Lynch syndrome suspicion or a carrier of the Lynch 2 syndrome, then definitely surveillance by examination, TVS and endometrial aspiration annually, starting from 35 years of age is required. And you have to offer them prophylactic surgery, which will include hysterectomy and bilateral salpingo-oophorectomy to all these carriers at the age of 40 years. So that is what we can say about the screening for CA endo. Coming to the clinical features, we have heard in the young and the perimenopausal women, it will be an abnormal uterine bleeding, usually amenorrhea followed by a prolonged and heavy bleeding. In postmenopausal women, it will be a postmenopausal bleeding. But remember, the advanced cases may present with something different. They may present with ascites, pleural effusion. So symptoms will be as per the site of metastasis. And then we get confused whether it is a CA ovary or it is a CA endometrium. So always in those cases also a detailed imaging of you have to see what is the endometrial thickness. Sometimes they may not even present with an abnormal bleeding. So these are rare cases, but yes, they do come. So diagnostic method, there was some discussion going on, and transvaginal sonography, of course, is the first step. Postmenopausal women, ET more than 4, we talked about that. Premenopausal women, what is it then? See, because the ET will vary according to the phase of the menstrual cycle. So in secretory phase, they say 16 mm, in the premenstrual, in the pre-ovulatory 8 mm. But even if it is not so, but the woman is not responding to medical management, there is a need to biopsy. Method of biopsy, as discussed, please do not say DNC. Endometrial aspiration is nowadays considered the best with PEPEL, or you use a simple Cummins cannula of 4 mm and attach it to a 20 cc syringe. We use it. I have been using it for years together, and it works wonders. higher sensitivity for both CA endometrial hyperplasia and a good specificity also. Of course, if there is a focal lesion or you suspect a polyp, there is an irregular endometrium, then it is better to go for a hysteroscopic guided biopsy, because that may be missed in the aspiration if it is just localized to one small area. So for discrete focal lesions, a hysteroscopic guided will be the first step. Transvaginal ultrasound with endometrial biopsy has a negative predictive value of 96%. So it's a good enough method for diagnosis. Now, precursor they were talking about, nowadays with the WHO 2014 classification, we have only two types of endometrial hyperplasia. One is without atypia, one is with atypia. Now, in the without atypia, the chances of coexistent CA endometrium or the concurrent is less than 1%, and the risk of progression is also less. Therefore, it's only the hyperplasia with atypia where there is a high risk, 25 to 33% of coexistence. So your biopsy report is showing hyperplasia with atypia, but there may be carcinoma sitting somewhere. And also, even if not, the risk of progression is with a relative risk of 14 to 45. So that's how hyperplasia with atypia is something serious. You need to take a definitive treatment approach. Talking about the WHO classification, we have seen endometrioid adenocarcinoma is most common, but probably not like 90%, little less. There are many others, just for you to remember: mucinous, serous, clear cell, undifferentiated, then neuroendocrine tumors, lots of them. There are some mixed ones also, epithelial and mesenchymal tumors of the uterus. Then the histopathological grading was commented upon, which is very important. So grade 1 are the well-differentiated, grade 2 moderately differentiated, grade 3 poorly. This is depending upon what is the percentage of non-squamous or non-modular growth, solid growth pattern in the tissue. So if it is less than 5% G1, 6 to 50% G2, and more than 50% is G3. So there is a good agreement on the tumor grade in the endometrial sampling and the final histopath. Of course, it will be higher with the hysteroscopic. So therefore, it is important that we get the grade in the endometrial biopsy tissue itself to help us tailor our surgery. I'm starting from the FIGO 2009 staging because till the books that we had of last year, we would be having this staging. It was a very simple kind of anatomical staging, that stage 1 limited to endometrium and limited to the uterus, 1A endometrium, 1B invasion to myometrium. 1A included the less than half myometrium also. Then 2 for the cervix, 3 was mainly the local extension, and the lymph nodes, and 4 was the distant. There is no mention in this staging of any other aspects: the biological behavior of the disease, the grade of the lesion, aggressive, non-aggressive, and some more things we'll just talk about. So this was the FIGO 2009 staging, which we all had been reading. And then came the prognostic classification, the type 1, type 2, which was included in the case discussion. The estrogen-dependent tumors and the tumors which are usually have a good prognosis and present in early stages, they are associated with mutation P10 and KRAS. And in contrast, the type 2, which are poor prognosis cancers, and P50 mutation was associated. After that came the risk stratification based on these things, and also the lymphovascular space invasion. So it was classified into low risk, intermediate risk, high intermediate, and the high risk, which were helping us to take decisions on the adjuvant therapies, which the questions were being asked from the PGs, that what will you do after surgery? So there was this risk stratification, but again, it was depending upon the stage, the grade, and the LVSI mainly. Now, what happened came this molecular classification of endometrial carcinoma. Once the Cancer Genome Atlas classification came, and we got these 4 types of genetic mutations in the endometrial cancer, which have changed the whole scenario. There is one polymutated, which is considered to be a very good prognosis disease, where the response, even if it is stage 2, the prognosis is good. Then there is a mismatch repair deficient, so MMRD, which are more related with the hereditary ones. Then there is a T53 mutation, which if present has a poor prognosis. So even if it is in the early stage, the prognosis is poorer. And there is this non-specific molecular profile, which is the low copy number. Now, I'm not going into details, but for the PGs, just to know that there is something like molecular classification which has come up, and based on that, a new staging has come up. Now, this molecular classification, if you have facility to do all that, you should first do the pole testing. If the pole mutation is positive, then it is labeled as endometrial carcinoma polymutated. If it is not, then you do the MMR, where if it is MMR deficient, then it becomes the MMR deficient ones. If that is also not there, then you do the P53, and based on that, you have either the P53 mutated or you have the NSM. So now, as I said, the new staging has come up just in this year itself. The FIGO has introduced it, and the aspect that have been included are the molecular classification, and also they have put staging according to histological type, aggressive and non-aggressive. And they can both upstage or downstage the disease. And so now the management protocols also will change according to these. So wherever facilities are available, they have to be incorporated in the final diagnosis of the disease. So just pay some attention on the FIGO 2023 staging, because in first go, when you read it, you find it very difficult, but it is not so difficult. I'll try to spend some time on this. So according to this, the stage 1 is now confined to the uterine corpus, as we said in the previous staging, but ovary has been added. I'll talk about it why. Now, 1A disease is further classified into 1A1, 1A2, 1A3. What is 1A1? Non-aggressive, that is your endometrioid grade 1, grade 2. All right, non-aggressive is endometrioid type, grade 1, grade 2, which is limited to an endometrial polyp or is confined to endometrium. That's okay. 1A2 is the same type of histology, but has extended to the myometrium, but less than half of the myometrium, and no focal LVSI. 1A3 is a disease which is a low-grade endometrioid carcinoma limited to the uterus, but simultaneously there may be a disease in one of the ovaries, unilateral disease inside the ovary, not involving the surface of the ovary. Then that is taken. And now the concept is that this is not considered a metastasis, but because the risk factors are similar, it may be a de novo disease in the two places, the synchronous, which we used to call previously. So if there are some criteria, I'll come to them. So if those criteria are fulfilled, it remains in stage 1A3. That is an early stage. But if they are not filled, then it becomes a metastatic disease. So I'll come to that a little later in more detail. 1B is a non-aggressive histological type with invasion of half or more of the myometrium, that is more than half, with no or focal LVSI. Now, LVSI also, they say no or focal when it is less than 5 vessels involved. Then 1C is aggressive histological type. So if the only the histology is different, which is aggressive, even if it is confined to the endometrium, it becomes 1C disease. I hope that is clear, but after I complete my session, if there are any queries on this, I'll be happy to answer that. Stage 2 is invasion of cervical stroma. So we have stage 2A, B, and C. A is invasion of cervical stroma of non-aggressive type. Stage 2B is substantial LVSI is present. So now LVSI has come up, but the histology is non-aggressive. Stage 2C is aggressive histology with any myometrium. So if there is aggressive histology with confined to the endometrium, it is in stage 1, 1C. If it is involving myometrium at all, even if little myometrial node, it straight away becomes a stage 2C disease. Makes sense. Then stage 3, where you have the involvement, the local spread of the disease. Now remember, stage 3 and 4 are the advanced stages where the molecular classification has not done much change to. So 3A is invasion of the uterine serosa, adnexa, by direct extension or metastasis. So 3A1 is spreading to the ovary and the fallopian tube, that is the adnexa. And this is where the criteria for 1A1 are not meeting. I'll repeat them later. 3A2 is involvement of the uterine serosa, subserosa spread through the uterine serosa. Now 3B is metastasis or spread to the vagina or to the parametrium and pelvic peritoneum also. So previously parametrium was not included in the CA endometrium staging. But here in stage 3B, the parametrium has been commented upon. So 3B1 is your metastasis to the vagina or the parametrium. B2 is metastasis to pelvic peritoneum. Once the disease goes to the lymph nodes, then pelvic or para-aortic, it is stage 3C disease. That's why when we are deciding to do the lymph nodes, it is for staging purposes. Then if the lymph nodes come positive, straight away it becomes a stage 3 disease. So 3C1 is pelvic nodes, 3C2 is para-aortic lymph nodes, and further divided into micrometastasis and macrometastasis. And here, this micro and macro is not whether you can see it with your eyes or not. It is up to 2 mm is micrometastasis and more than 2 mm is macrometastasis. And then stage 4 disease is, of course, advanced disease. But, it is still in the pelvis. If it is the bladder or the intestinal mucosa, it is 4A. So it is still in the pelvis, but it is stage 4A. If it goes to the abdominal, it leaves the peritoneum, goes to the abdominal peritoneum, then also it is stage 4 disease. So that's the difference between, like when you see CA ovary or something. Stage 4C when there is a distant metastasis. So disease of endometrium going to the abdomen also is a stage 4 disease. So some other important points which I was mentioning, the first one, that was the stage 1A3. That is when you have a disease limited to the uterus, but there is a lesion in the unilateral ovary. It is a synchronous tumor, and that's why it remains in stage 1A3. The criteria to say this are no more than superficial myometrial invasion. So myometrial invasion should be less than 50%, absence of any LVSI, absence of additional metastasis. And the ovarian tumor is unilateral, limited to the ovary without capsule invasion or rupture. Then a point about the grade and histology. As I said, endometrioid adenocarcinoma grade 1, grade 2 is non-aggressive and rest is aggressive. And for the endometrioid adenocarcinoma, grade is based on the proportion of solid areas, which also I mentioned. Now, LVSI, as I said, more than 5 vessels involved will be called a substantial LVSI. Less than that will be a focal or nil. Then macrometastasis, this also I told. There are a few more other important points, that presence of any unusual nuclear ATPR, it directs you towards evaluation of P53 because it is a poor prognostic marker. Then adenocarcinomas with squamous differentiated will be graded according to the glandular component. Now, where molecular profiling works best is in the high-grade endometrioid adenocarcinoma. So in the endometrioid type, if the grade is 3, then here molecular addition of the molecular profile, whether it is poly or it is P53, this will make the huge change. So this is the category where maximum role of molecular profile will be there. So if you have the facility, see in most places, I'll tell you with the IHC, like in my institute also, with the IHC as a surrogate marker, they can look for P53 mutation, they can look for MMR. Only poly mutation is not available. So if people ask, most of the pathologists will be able to give these two, but poly, only few high-level centers will be having. So this helps us in giving, if it is there, then when this molecular, it comes poly or P53 or MMRD, then you label it as the stage. Along with that, you put the M, that is molecular, and then what mutation is there. Like for P53, you'll write 2CM, P53 abnormals. You can see that. And so for practical purposes and to avoid undertreatment, if the molecular classification is unknown, then high-grade EEC will be grouped together with aggressive. That's why we said grade 3 endometrioid will go as aggressive. So automatically the staging will get upgraded. Now coming to the treatment part, how will you treat? Surgical staging will be required. So it's a comprehensive surgical staging. You'll give a midline vertical incision. You'll take peritoneal washings, although there is no mention of peritoneal washings in the staging, but this will continue because times to come, we may change our staging further. Thorough exploration of the peritoneal cavity for any evidence of gross metastatic disease. If it's not there, what you do is an extrafacial hysterectomy with bilateral salpingo-oophorectomy, and then the lymphadenectomy, which are the cases to be done. We'll just come to that. Previously, people said if cervix is involved, do a radical hysterectomy, just like cervical. That is not the concept now. Omentectomy will be done in cases of uterine papillary serous cancer. So when there is a serous cancer, it behaves like ovarian. And there, or if there is a metastatic disease, obviously you will have to do that. So now coming to lymphadenectomy, what are the indications? If the tumor size is more than 2 centimeters, if the myometrium more than half is involved, if it is a moderately or poorly differentiated disease, if it is aggressive histological subtype, if it is cervix or adnexal involvement, if there are enlarged pelvic paraiotic nodes. Now, out of all this, how will you decide all this? You should know this preoperatively. So some of the features will come in the endometrial biopsy report. That is the histology, the grade, the molecular profile, which is not yet added, and the LVSI also actually comes here only. So these 4 things should be there now. If we are getting a histopathology, we should discuss with our pathology friends and ask them to give that. And you do it and it will happen gradually. Then rest of the things, the myometrial involvement, cervical involvement, adnexal involvement, all this, and the lymph nodes, this will come from the imaging. So contrast enhanced MRI is a good modality to look for all those things. And then on the basis of this, we will decide whether we go for a lymphadenectomy or not. Now, so a preoperative MRI will be very useful. High sensitivity accuracy is good to do that. Now, there have been, what about if you do not have a good this thing, or when you open, you are finding something different. Your MRI said it is limited to endometrium, but now you are finding what to do now. So now on gross examination, you can see, but if you have frozen facility, intraoperative frozen can help you in both, in all of these further. So there are studies which have shown that these are good methods, frozen section. If you have the facility, you can confirm that better than the gross examination. Then what is the role of this lymphadenectomy? One should understand. See, the one role is to stage the disease, because gross disease is not there, but lymph nodes come positive, because the risk of lymph node metastasis is high in all those conditions where we have said lymph node should be done. So that will upstage the disease. So your adjuvant treatment will be decided on that. But apart from that, therapeutic advantage is there only in the advanced disease. So in early stage disease, there's no benefit in the overall or recurrence-free survival. Lymphadenectomy, therefore, is not recommended in the early stage endometrioid, whatever criteria we give. Then the paraiotic lymph node survival benefit is there in the intermediate or high-risk disease, and benefit increases with high tumor grades. So as I said, in the high-risk disease, in the intermediate risk disease, which also means a higher stage disease, it will help you. Then there is a role of sentinel node biopsy, which can be done to, reduce the morbidity of complete lymphadenectomy. So that can be done wherever facilities are available. I'll not go in details, but a lot of work has been done and it has been found to be useful. C-endo is one where it is really useful. Now, treatment modality, there was a question. Minimal invasive surgery should be embraced as the standard surgical approach wherever expertise is available. If you're doing open because you don't do lap, doesn't mean you're doing wrong. But point is, those who are doing lap is good enough if they have the expertise. Power morcellation should not be used. Robotic assisted lap staging is also feasible and a safe alternative. Then there are trials, so I'll not go into, just remember there are some good evidences available for what we are saying. So the GOG Lab 2 trial was there, and the update has also come, which shows that the long-term survivals are also good. Similarly, in the Cochrane reviews, lap versus laparotomy and robotic versus laparotomy. So a lot of studies are there, and not just the perioperative outcomes, even the oncologic outcomes, and are good enough with these modalities. Vaginal approach, there was a question on. So see, approach for a retrospective study is there, which is a little old one, which has shown that it can be, but then in select patients only. And it is appropriate maybe for early stage endometrioid cases where you don't have any doubt of, need for lymph node. But then to be very sure, I feel is very difficult always, because we are basing our decision preoperatively on imaging and histopathology, which also may not be 100% quite good, but then going for vaginal, that is how the point will be there. So now coming to what to do after the surgery. After the surgery, who will need adjuvant therapy, who will not? So if it's a low risk disease, which stratification I told, see at present we have that one only. Now with the molecular profiling, we will have some more changes in these tables also in times to come. So in low risk disease, you can just observe, but if it is low intermediate, but there is only a single risk factor, you may observe. But if it is a high intermediate disease, 2 or more risk factors like age more than 60, deep myometrial invasion, LVSI grade 3. So here vaginal brachytherapy is required, what sir was asking. So that is a vaginal brachytherapy to prevent the local recurrence. But if it is a high risk disease, then in those cases, the external beam radiation therapy or a combination of chemoradiation, depending upon the stage of the disease and the type of risk factor, will be required. In advanced disease, it will be chemotherapy alone, even radiotherapy will not be working and they will need palliation or something. So this is also based on a lot of trials. The POTEC trials, sometimes PGs may be asked, POTEC 1, which showed that the impact of postoperative brachytherapy on local regional recurrence seems to be limited and low risk. So here you do not need to give. In the, the POTEC 2 told us that vaginal brachytherapy ensures vaginal control with fewer GI toxic effects, adjuvant treatment of choice in high intermediate risk group. And then about chemotherapy, early stage, it does not have any particular role in improving the survival. In high risk disease, yes, it is. And in advanced, as I said, only chemo. And what we give, as sir said, carboplatin, paclitaxel, 6 cycles is the standard of care. Combined chemo radiation, the POTEC 3 trial and the GOG 253, so 58 trial were there, highly efficacious in cases of cases with higher chances of recurrence. So there, advanced disease with very poor prognosis, you may give the combination. Talking about hormone therapy, no survival benefit in the meta-analysis has been found. And only in some recurrence cases, also if you are planning to give, you retest it and look for ER receptors. So there only it will be actually useful. Now, this is a slide showing based on the adjuvant treatment based on molecular classification. Now, this is the only good thing to remember, that if it is polymutated, even if it is stage 1 to 3, no adjuvant therapy, because so that is the de-escalation. So lot of work is being done and lot of more information, but for PGs, I don't want to load you with that. Just have an idea that these things are coming up and they will change the protocols further. So there are some double classifiers also. Sometimes if you have both P53 and pole mute, remember pole mute has a better prognosis, even in combination. Similarly, MMRD with P53, MMRD has a better prognosis. So, okay, now coming to these two are important. Now, surgically or medically inoperable disease, as they were talking about neoadjuvant chemotherapy, yes, if it is an advanced disease, you do a neoadjuvant chemo for 3 cycles, see the operability, take up. So just like in ovarian, you can go for these cases. Then there is another situation, diagnosis post-hysterectomy. This I want PGs to remember. Many times when people do a hysterectomy without a good endometrial biopsy, without any emphasis on the intraoperative care, they just do a hysterectomy and post-op, you got the disease now. What to do now? Now, in that case, if it is a grade 3 lesion, there is a deep myometrial invasion on the final histopath, then additional surgery is required to remove the adnexa and the lymph node, or you directly give external beam radiation. But if it was a disease which was grade 1 or 2, endometrioid with no myometrial invasion, LVSI was negative, then maybe those cases may be left for follow-up, but not sitting at home every 3 months and look for any recurrence at any time and then you. So this is an important component because it happens many a times. Now, role of fertility preservation, just to tell you, you will read articles, there are a lot of this thing, but patients should be counseled clearly. There will be select patients who can go for it. They should know that the standard treatment is complete surgery. All the risks and benefits should be explained, and then only you should offer, and only experts should offer, and it should be in, it should be an MDT, multidisciplinary team decision. So I don't want PGs to. The drugs that we have are progesterone-based therapies, LNG, IUS with medroxyprogesterone acetate. So, or megestrol acetate. Not telling you much about, but finally, if she conceives and has a baby, later a completion surgery required. Ovarian preservation can be offered in younger women if the woman is less than 45, and the disease is grade 1 endometrial carcinoma with myometrial invasion less than 50 and no obvious ovarian or extrauterine. It may be offered in these women. Now coming to the post-treatment surveillance. As you know, any malignancy risk of recurrence is maximum in the first 2 to 3 years. So a very close follow-up is required. Every time she comes, every 3 months, you do a clinical examination, look for symptoms, examination findings. Imaging will be needed only when there are any symptoms or signs. Initially, you do it 3 monthly for first 2 years, then every 6 months or annually, depending upon the symptoms. And genetic counseling for patients who have a family history suggestive of Lynch syndrome should be done in this time now, after she has been treated. Management of recurrence, mostly if it is a localized disease, then surgery can work. But if she has not had RT previously, RT is good for her now. And if it is diffuse disease, then also RT or chemotherapy. Not going into details again. Survival rates stage-wise are, the previous data only. Newer ones will come later. Role of MHT, menopausal hormone therapy can be given or not. So, in CA endo, of course, you will think you'll go give estrogen, it is going to further. So don't give in the first 2 to 3 years where the risk of recurrence is maximum. And after that, maybe some symptomatic treatment may be given. So that was it. The take-home messages. Incidence is increasing with changing lifestyle. Tissue diagnosis by EA with the type and grade is important. Pre-op CE MRI for the extent of disease so that you can tailor your surgery. Lymphadenectomy, particularly for staging, is important. SLN biopsy may be done, may replace the complete lymph node dissection, and MIS has to be embraced. Vaginal brachytherapy for intermediate risk, EBRT for high risk, and chemo for advanced stage disease. Follow-up and all I have already talked. Thank you so much for this patient hearing. If any questions, I'll be happy to answer them.
Wonderful presentation, Dr. Nisha. I mean, this should go with all the PG students as the presentation for their preparation. They don't need to go to the books. I think it's quite exhaustive. And, unfortunately, today only we saw one patient. She's just 37 years old. Who's trying to conceive, PCOD patient. And the last ultrasound showed some polypoidal growth. And we took a biopsy, and today we got the report as an endometrial cancer.
Yes.
So unfortunate, because she was under treatment for PCOD for 1.5 years. So very, very, you're right that it is coming in the young age group.
Yes.
And we should be very careful in treating the cases also. Like you said, that the biopsies are very important. The pre-op, MRI needed for proper staging should be done. And I think involvement of an gyno-onco surgeon is very important. I think medico-legally also we will be in a safer, environment rather than doing it ourselves, because we are doing right, left, hysterectomies, and I suppose better staging and better management. We should have a, proper oncosurgeon with us. And for the fertility preservation, I would like to ask you. You said that we have to have the patient selection. So can we offer this patient how can we offer the fertility preservation to this patient which we saw, which we were treating?
So as I said that, because it is a medical management, everybody feels anybody can give it to any of the patients who come. That's why I said it is very important, a proper counseling. So again, looking at all those factors, does she fit into that? The histological type, the grade, the myometrial invasion, all that will first. So it has to be a disease limited to the endometrium only. It has to be an endometrioid. It has to be a grade 1, grade 2 disease. So that is first regarding the disease. Then the patient has to know that this is not the right treatment. The right treatment is a hysterectomy only. But because she wants, so she has to understand that whatever treatment we give, it may work, it may not work. If it fails, or this may increase during that course. So she will be on a very close follow-up. We'll have to repeat the biopsies. And if there is, it goes away, then there will be a trial of conception. So all that is very important. Then only, so the treatment will be, it can be given. So you have to see all those things and then take a decision. So involvement onco-surgeon and also a fertility expert. What can they give for the ovulation induction? Because you can't leave her on a normal spontaneous then, if you are doing like that. Yeah.
Thank you so much. And thanks, Dr. Pragati, for inviting me for this wonderful session. Really exhaustive and very nice. Interesting.
It is our pleasure.
It's some
Thank
question
you,
or
Dr. Nisha. So that was so good, but I want to add one thing to your armamentarium. You said that you have to do a contrast enhanced MRI for diagnosis. For spread, okay, but as far as local disease, a 3D ultrasound works so well. With Doppler, you put the correct PRF at 0.3 or 0.4, put in a Doppler and do a 3D. You can see the complete extent of disease. You can make out preoperatively how much of the myometrium is involved, whether the cervix is involved, whether it is going into the parametrium. Because when you're doing a good power Doppler, along with a 3D, means I have been able to diagnose 90% of my patients 100% correct in this manner. It's only one patient who was 34 years old and 140 kg. Means I couldn't really do anything for her. We got that, yes, she is endometrial carcinoma. We had to get her operated and it turned out an early stage disease, but she was Lynch syndrome. So the basic thing is, we as gynecologists are so used to looking at the uterus that we should put in that probe. And today, almost every machine has that Doppler capacity. Train your eyes, because what your eyes don't, your mind doesn't know, your eyes will not see. But you can definitely make a very good diagnosis wherever you are.
So Dr. Asha.
And it was a great refresher for me, reminded everything.
Yes. So actually, this was a PG session. That's why for many things I stayed on, the standard things. But of course, because if you see, like for CS cervix also, they are talking about, use of uterus for the parametrium and all that. So there are a lot of things that are coming up. I try to put some not, it becomes we just try to.
But actually today, a gynecologist is allowed to do ultrasound because of their PG training only. So they should actually get it into their heads what that machine in their hand can do.
True. And I understand, because Dr. Viren in the case discussion also said, so gynecologists have to learn to do their own scans and then looking at the endometrial thickness, extent, everything. So obviously this is an additional thing but lymph nodes may or may not be, I do not know.
Agreed. That's what I said.
The point. Yeah. Okay.
See, if more than half endometrium is in myometrium, you're going to go for an MRI anyway. But what I'm saying is, in routine cases, where you said that so many patients are getting operated without a diagnosis.
Right.
So if you have done a good quality scan, you will be able to guess. Put in a Doppler, you can see the vasculature, you can see the break in continuity.
Dr. Pragati was
Thank you, Dr. Pragati, for having me here. Thanks a lot. Thank you, Bhakti. And thank you, Dr. Nisha and Dr. Kachru ma'am, for being here.
Thank you so much. We gained knowledge.
He's also there on the board. So, sir, you want to put in some special comment? I think he is there. So, anyway. So, it was really a very thought-provoking and very in-depth discussion.
Really good.
Yeah. So, I should proceed with my vote of thanks, I suppose. Right? Megha?
Yes, ma'am. We thank all the speakers for being here tonight and the chairpersons for chairing the session. Now I request Dr. Pragati Karatkar ma'am to please offer a vote of thanks for the night.
So it is really indeed a pleasure as the year is coming to an end. So people are looking after the coming year, but I am always, in a feeling of gratitude that this whole year has given me so much things I have learned. I've met so many people. I have learned so much from them. So my gratitudes to last passing year. And so happy to meet my all dear friends on this PG Star board. My God, this program, I am secretary to Nagpur OBGYN Society, and this is my favorite program of the year. Very meticulously, our team, PG Star team, has worked, and this was our 17th session. So, my thanks to DMMIS for presenting the case, getting associated with us, all the medical colleges around Nagpur, that is GMC, IGMC, DMMIS, Lata Mangeshkar Hospital, and AIMS Nagpur have all collaborated and come in for this PG Star activity. And very glad to inform all the people who have logged in and all the guests who are here that our viewership was in the tune of 800 to 1000.
Great.
And we had global delegates as well. Global students were also benefited with this unique program. So we feel so, so thankful, and we feel so satisfied in conducting this program. So for today's speaker, Dr. Nisha Singh, my dear friend, I was just trying to get you on this program, and at last, in this year, I could do that. Thank you so much for your so elaborative talk. Today's chairperson, Dr. Chandan Petru and Dr. Asha Jain. Thank you so much. Ma'am, your tips were so good. Dr. Asha Jain and Dr. Chandan was busy, and I pulled her, and immediately she was here. And so many times we were missing the train that I was to want to call her in the Nagpur OBGYN program, and then we are here. So we are so grateful. Today's expert examiner, Dr. Virendra Kumar sir. Sir, you have thrown such a light and so practical tips provided, not only to the PGs, but for the practitioners like us. And definitely it will be beneficial in our day-to-day practice.
Thank you, madam.
Yeah. Dr. Swati, you presented the case well. And Dr. Megha, thank you for being the MOC. And I should really ask all to give a standing ovation to our PG Star team, Dr. Bhakti Guzar, Dr. Prachi Dikshit, and headed by Dr. Anuja Bhalerao. They are doing beautiful job. Whole program is chalked. Dates are getting clashed. Festival season, carnival season, but PG Star do happen. Thank you so much, and all the delegates who have logged in. Thank you so much for logging in the program. And shortly we'll get the link of this program so it can be circulated in your respective groups. Thank you, and wish you a very happy coming year. Thank you so much.
Thank you, ma'am.
Thank you so much. Thank you so much, everyone.
Happy New Year.
Happy New Year.
Thank
you.
With this, we come to an end of today's program.
Team Core Connect. Thank you for connecting with NOGS. Arush Core Connecting, they are working so tirelessly. They make our flyers and post them at time, and then they send the link. So thank you so much. Thank you.
You're welcome, ma'am.
Thanks a lot.
So our live is off live. Dr. Nisha, stay back. Dr. Chandan, stay back. You can. Corona is live is off.
Sorry, I just